this week on the BackTable podcast.
I love talking about sex. I get to talk about sex and satisfying orgasms all day, every day. I don't know why more people don't want my job, but there are some people that don't want to have those conversations, and that's fine. So understanding for ourselves, when it comes to this digital footprint, how do each of us communicate best? But I don't think the answer is for all of us to get Instagram and YouTube and Twitter and TikTok and to communicate all of those platforms. If one, we don't enjoy it, and if two, we're not good at it and don't come off well on those platforms. So we have to be honest with ourselves to understand what are we good at and what are our goals.
Hello, everyone, and welcome back to BackTable Urology podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. Now, a quick word from our sponsors. Our next partner has a product I use literally every day. I started taking AG1 without any expectations at all. I definitely feel healthier. The important part for me, I personally like to try a healthy diet from what I can. For example, I go to a local farm to get beef, pork. Yeah. But in terms of the sides, that's my challenge. Yeah. I'm not of a leaf eater in that sense. Not that many greens.
Right.
And having a product that supplements that or fills that gap or that void that I have in my diet, it is great. And I think my hair is better. I mean, something as stupid as that. I'm not sure if it's the trick. I don't want to promise anything to the people out there, but I feel good. I've been doing it for the past 4 weeks. I'm doing it in the mornings. Yeah.
Hair looks good today. I mean,
it does.
It might be something there.
Thank you.
It's funny you said that about the greens because, Chris and I were talking about being just kind of like a cheeseburger and fries guy. I feel like I don't have to worry about, did I eat a salad this week anymore, with the athletic greens. So there's definitely that. And, what I did ask in the beginning, and my wife asked me this when she started taking it, was, what is this stuff? Like, what's in it? And so with one scoop of AG1, you're actually absorbing 75 high quality vitamins, minerals, whole food source superfoods, probiotics, and adaptogens to help you start your day right. So, it supposedly helps with gut health, your nervous system, your immune system, with energy, like you said, helps with focus and aging. And now that I'm in my mid-40s, I definitely need some help with aging,
To make it easy, Athletic Greens is going to give you a free 1-year supply of immune-supporting vitamin D and 5 free travel packs with your first purchase. All you have to do is visit athleticgreens.com/BackTableUro. That's /BackTable URL. Again, that is athleticgreens.com/BackTableUro to take ownership over your health and pick up the ultimate daily nutritional insurance. Now, back to the show. This is Jose Oche Silva, your host this week. We are happy to have as a guest this week Dr. Amy Pearlman. Dr. Pearlman went to University of Miami for undergrad, then did medical school at Baylor College of Medicine, followed by urology residency at University of Pennsylvania, and lastly, a fellowship in urology, reconstruction, prosthetic urology, and fertility from Wake Forest. Currently, she's the director of men's health at University of Iowa. Welcome to BackTable, Amy.
Awesome. It's so good to be here, Jose.
So prior to talk about what you do, I want to talk about yourself. Essentially, all the trajectory you've been in Miami, Houston, Philly, North Carolina, Iowa. So talk about how you ended up eventually, how you ended up in academic program in Iowa, but just go through the process.
Yeah, Jose, as you mentioned, I've been kind of in all sorts of places around the country. I grew up actually on the East Coast in the state of Maryland, and then I had the opportunity to train all over. I did my undergrad at University of Miami. I told my parents I wanted to go there for their incredible pre-med program, but really I wanted warm weather and something completely different from what I was used to growing up in Maryland. And then I went to Baylor College of Medicine in Houston, and I went there because I had the opportunity to train at the largest medical center in the world And even though I only took advantage of probably 0.0001% of the opportunities in that campus, it was an amazing place to be during training. My journey then took me to University of Pennsylvania in Philadelphia. And at the time, I was looking to work at a program that I knew was going to kick my butt. And I knew that the University of Pennsylvania was going to be the place where I was going to work really hard and learn a lot. And that was one of the reasons why I chose that program. And then I did a 1-year fellowship at Wake Forest in North Carolina. One of my colleagues who was 3 years my senior did a fellowship there, and I trusted him, his guidance, I respected him. He said he had an incredible opportunity doing his fellowship there. And so really based on his mentorship, I decided to go to that program for a year, which is where I really learned and appreciated doing men's health. So it wasn't really until my fellowship that I developed an appreciation and interest in men's health and quality of life concerns regarding those patients. And then let's see, what took me to the Midwest. So this has been the first time that I've been in the Midwest. I didn't know anyone in the Midwest. I was so used to moving to so many different places during my training that moving to a new location where I didn't know anyone, that wasn't scary to me. I was used to that already. But the job opportunity brought me to the Midwest. And it was an opportunity to have a leadership role just starting out in my career. And that leadership role has been probably one of the most meaningful things that has happened in my career thus far. It allowed me, when I was developing this team, which we'll talk a little bit more about, it allowed me to introduce myself as a new faculty member to say, hey, I'm Amy Pearlman. I've been here 2 months. I direct our men's health program. I would love to meet to talk about how we can collaborate. So that leadership title helped me set up a lot of meetings early on.
So you went straight into being the director at the men's health clinic.
Yeah.
So was the men's health program already running or when you got there or you actually, they brought you in to build it?
It was already running, and I actually feel very grateful for that. There's kind of a balance between, starting in a new place where I prefer that there's some infrastructure already in place so I can build upon that infrastructure rather than having to have meetings with a variety of different people to even introduce the idea that a men's health program and that men's health is important. So that was already established. In fact, one of our nurse practitioners had been asked to lead that program about 4 or 5 years before I got there. And so my role when I joined was to work with that person to help educate him because he was actually self-taught doing this work. And so we worked together and were able to expand on that program.
And when you got there, did you already have in mind what you were going to do? I mean, you already had your picture of what a men's clinic looked like, or how did you evolve into that? I mean, it's something you saw it before you went there. You learned it from Wake Forest. Where did you have that background?
I had an idea. And as you mentioned, I really did learn that from my time at Wake Forest. When I worked with Dr. Terlecki, who was my fellowship director, as part of being the fellowship, sure, I was in clinic with him and I was operating with him. But where I really learned so much during that year was any meeting he had, he brought me along with him. So when he was meeting with key stakeholders in terms of him building his comprehensive men's health clinic, I was with him during lunch and in meetings after clinic. And I saw him in a room with administrators with a marker and a whiteboard mapping out exactly what he envisioned. And he spoke about the financials and he spoke about what he wanted to build. And that's really how I learned even how to run a meeting and how to bring these ideas, to other people that are outside of men's health. So even if I didn't operate at all during my fellowship, just learning how to build the team.
Yeah.
And how to talk to administrators was worthwhile for my fellowship. And then when I got to the University of Iowa, I had some ideas as well. And so my goal, year 1, was to build the team. And that meant that while I was still building my practice and had time, I sent out hundreds of emails. And I would start out by emailing the chairman, for example, of a department, and I would introduce myself and say, is there anyone you think on faculty who may have an interest in collaborating? And then oftentimes those people would give me 5 names and maybe send an intro email. And then immediately I would send an email to those 5 people. Or I would go on the website and see all the people in the endocrinology department and send individual emails to each of those people. And I wasn't looking for 10 people in a single department to respond. I was looking for 1. That's all I needed. And because I had some more flexibility in my schedule, I would send an email out. I would meet them whenever it was convenient for them, wherever it was convenient for them. And I would ask them what kind of coffee they wanted. So that was my year one plan, was to build that team.
Awesome. So you mentioned the team. I mean, what's the team? You're talking MAs, you're talking referral. When you mention team, what do you mean?
At the very basic level, it's what I would refer to as a referral network. A lot of the patients that I see, so, when we talk about men's health, I look at that actually not as us being gatekeepers as urologists. I look at it as one door into the healthcare system that some people will walk through. And there are a lot of doors that people walk through to get into the healthcare system. Urology, men's health is one of many. So I look at that as being an opportunity. But we're all seeing the same patients. The guy who sees me for low testosterone concerns is also the guy with right shoulder pain who sees one of my musculoskeletal specialists. So when I mention this referral network, it's really, asking myself when I'm seeing a patient, how am I going to send this patient to the right provider at the right time? And just because I'm not a primary care provider doesn't mean I can't help my patient navigate the healthcare system. So I try not to tell patients to, oh, we found this on your CT, go back to your primary care provider and talk to them about it. I mean, sometimes I do if their primary care provider is out of our institution. Or I think you have sleep apnea, so talk to your PCP about getting a sleep study. I order those sleep studies. But the only way that I know kind of what tests to order and what the follow-up is I've reached out to all those specialists to better understand their clinic flow, their clinic access, and the services. So when I refer a patient to see someone, I am referring them for the most part to a specific person to answer a specific question. And I'll give you an example. So if I, let's say, see a patient and he has significant heart or lung disease and doesn't qualify for an at-home sleep study, because usually those are reserved for people who don't have significant heart or lung disease, I am referring that patient to the sleep clinic to assess the appropriate way of deciding if they have sleep apnea or not. If I'm referring someone to a cardiologist, I have a few cardiologists that I work with, and the three of them have different personalities. So if someone really needs to understand the scoop between all the different testing and understand, the impact of nicotine, the impact of lifestyle, nutrition, all those things, well, I'm going to send that person to my girl, Linda Lee, because she is the real deal. She is not going to sugarcoat anything. But some of my patients may not jive with that message. So I want to make sure I'm sending the appropriate patients to someone where they're going to get the type of care that they're looking for. And then I'm really trying to set everyone up for success. So that referral network, they have names, they have faces, they have personalities. And my job in those instances is to be the matchmaker of my patient with that person.
And that's great. I mean, hopefully I have, but unfortunately I don't have that in the system that I work in. For example, once a patient with erectile dysfunction had uncontrolled diabetes, I sent to the endocrinologist to get the sugar under control. The PCP called me saying, why are you going over me? And since then, I took a step back. I mean, sometimes I do send directly to my network, but depending on the PCP, I already have been in the process of getting to know some of them. And I guess that's important from what you're saying from the network. You get to know the others, you have to know how they work and go from there.
Yeah. Well, and you bring up a really good point, because that's all kind of part of building this network is everyone's going to have their own preferences. And honestly, it's easier to tell our patients to go back to their PCP. I just know it's hard to get in to see someone's PCP. And so that's why I try to make it easier. But it's just as helpful to know that they want to see those patients back to manage that than to place the referral. So really, it's just asking the question. Some of the ways that I did that is I would sit down with each of these people and I would say, I know what types of patients you see, but who do you like to see? Who can you help? Who, when I place a referral and you see that patient in your clinic, will you say, hell yeah, another Pearlman referral versus God damn it, another Pearlman referral? And I'm always looking for the former.
And it is exactly what you're saying. I mean, it is about asking the question, because I always go to the PCPs to promote myself. Hey, I'm here. Send me patients. But I never ask them, hey, what do you want to do? I don't get to that part. I'm available. But it doesn't get to that point, like to have a real relation with that PCP back and forth. Sometimes I do. I give myself onto everybody, but I mean, sometimes we don't build the rapport with them. Amy, in terms of the support of the hospital, how I mean, you mentioned Wake Forest, you learned how to sit down with the administration, all that. Was it easy? Were they looking for a men's health clinic?
I think what made it easier for me, and I don't know, something happened when I finished training when you kind of feel like there's no one looking over your shoulder all the time, watching every move that you make. And so I still really care about what others think about me and about the things that I do. But often I care a little bit less. And also because I'm not from the state of Iowa, I came in like not knowing anyone. And I know that no one, if they see my mom at the grocery store, like they're not going to see my mom at the grocery store and say, I can't believe Amy asked for that. So I don't know. I ask questions. I asked to do more and for different things. And I am not afraid of the answer no. That doesn't scare me anymore. If the answer is no, I get it. I might try to ask it in a slightly different way to change that answer from a no to a yes. But I'm really trying to get it like, well, what would it take to make this happen? And what I've also understood over the last 4 years is some of what I want to do is going to be done within the academic center in which I work. And some of it just isn't. And I'm okay with both. And when I've presented before to our faculty members on building a digital footprint, and one of my colleagues made a comment asking, so are you going behind marketing's back with some of the stuff that you're doing on social media? And the answer is no, I'm absolutely not. At the end of the day, my job is to educate patients and to empower them. And part of building a digital footprint is being able to do all those things. And the reality at any institution is I am one of many providers. So I understand that just because I want to build certain things online or educational materials, I'm not the only one that's hired, to take care of patients. So a lot of the stuff that I've done over the last 4 years is outside of my academic institution. And it's okay. It's not illegal and I can still educate patients. But it's something that I've learned is that it's going to be a mixture of what I do with my institution outside the institution. So I would say, to get back to your question, my institution doesn't micromanage me. My leadership doesn't micromanage me. I get to do the things that I believe are the right things to do, and they allow me to do them. And part of that can be a little bit overwhelming for providers because when we enter into an institution, we would love for them to be able to help us educate and do our education material and do our social media. But because they don't have the bandwidth, then it's on us to do that. And then that means we can do it, but that's a lot of work. And I think that's a big barrier to people doing it is all of a sudden no one has to do it for us and it's on us. So that can be certainly a barrier for a lot of people.
And you mentioned the digital footprint. Right? How important was or is social media in that process? When you started being very active in social media, was it in fellowship or you got to Iowa?
I started about 3.5 years ago. Boston Scientific had reached out asking me to post a question as part of one of their initiatives during the AUA. And so I kind of reactivated my Twitter account. And in the beginning, I found Twitter to be very annoying. So I was only on Facebook and didn't have anything on YouTube or really on Instagram either. So it was really over the last, I would say 3.5 years that I started building those social media platforms and really understanding what is the purpose of each one? What can I do with each one? And, to be honest, I wish I had started earlier because in training, you're kind of limited by the people at your institution. And while those people are really awesome, social media allows you to network with any single person you want around the world, and you can access them in real time. And the people who are really active on social media, they'll respond in real time, and you don't have to search to find their email. So social media has been huge to allow me to network outside of my institution. And I wish I had started sooner.
And in terms of education to the patient, educating the patient, what are you doing? What initiatives are you doing? What platforms do you find more useful to educate patients?
The main way that I educate patients are really just people in the community, and some of whom actually become my patients because of some of this work, is going to be through YouTube. So YouTube, I use to create short videos anywhere between 5 minutes, and some of them are actually 60 minutes for some of the webinars that I've recorded. But, during COVID, with everything being recorded on Zoom, that really gave us the opportunity to record everything and post it. Even if it's something we recorded for other providers, there are really, thoughtful patients out there that want to hear the same conversation that we're having with our colleagues. And so I post those webinars as well. So YouTube is what I use to educate patients. I want people to see what I look like and to hear my voice and to hear my message and to understand what types of questions I'm going to ask them before they come see me and what type of treatment options I have. Because if they don't want to see a young woman, or if they don't like my message, or if they don't like my treatment options, I want them to know that information before they wait 2 to 3 months to see me and then see me in the office. So I want them to hear my message beforehand. So if they cancel their visit, you know what? I'm not going to know. I literally will have no idea that they canceled their visit, and that's okay. I take no personal offense. If I were to call a gynecology office and if they were going to ask me if I preferred seeing a man or a woman, honestly, I'd say a woman. And if a guy said, well, I'm just as good as the female gynecologist, why don't you see me? I would say it's not about you. It's just about my comfort level, And so that's the same for the patients who want to see a men's health provider. And that's why I am trying to train as many people as possible to do the work that I do so that people can see someone they feel comfortable seeing. And so that choice for a lot of patients can be crucial.
So are you saying that you have male in your office to see patients?
Yeah, so I train physician assistants. And one, it helps with better access for patient care. And two, I know that some patients are going to want to see a man. And so we can still provide that service for them, and they can see a man that, I work with closely. So if that person has a question about what to do for a patient, I can still provide guidance, even if they prefer to see a man.
In terms of the workflow or the logistic, when the patient comes to the office, do you give me any papers to sign? Like, for example, any CHIM score? Are they seeing the PA first? What to be expected from a men's health clinic, at least yours?
So when patients check in, most of them actually get a packet. And this is a packet that I've created. And the first page on the packet has a bunch of online resources, my YouTube channel, my website, and recommended products that are for all sorts of men's health concerns. And then this packet, as you go through it, goes through all the different ways that we can restore sexual function. So even if my patient is coming in for low testosterone concerns or urinary concerns, most of my patients will still get this packet. And I do that on purpose. One is because sexual health is going to be something where a lot of people come in with that concern. But for people where they're coming in with something else, oftentimes they also have sexual function. And I use the packet to normalize the conversation. So they know if it is something they want to talk about, it is expected that they bring it up. It is normal. And oftentimes people will say they're coming in for a different reason. Oh, I saw in the packet. Or I'll bring up during the conversation, I know you're coming in with a concern about urination. Sexual function is also something that I commonly see in this clinic. Is that something you would like to discuss today? And sometimes people are like, well, what do you mean? I'm not sure. And then I'll say, any issues getting or maintaining erections, Or sometimes people will say, no, I'm not worried about that. Fine. Then I drop it. I don't ask any further follow-up questions. But I've learned it doesn't matter who's in the clinic room with that person. It could be mom, it could be sister, it could be daughter, uncle, friend, whatever. If you bring up the question, any sexual function concerns today, or sexual function concerns are common after prostate cancer treatment, is that something you would like to discuss today? It's really difficult to offend anyone in the room, and it opens up that conversation. Also, if they say, no, I'm not worried about it, I will add, if it becomes a concern of yours in the future, I want you to feel comfortable bringing it to my attention, and I'm happy to discuss options. So they get that full packet. Most of my patients do.
No, that's awesome. Because definitely, I always ask my patient for BPH. I ask, hey, and when you ask them, they say, well, I'm not like 10 years ago. I'm not like 15 years ago. And is there something? Because there's always the stigma from pills, from that they're going to have a heart attack or something like that. So definitely when you bring up the conversation, most of them, they don't know. And it's about education. They don't know what to expect. They hear bad things from, I don't know, other people. Sometimes it's even the wife, the one that tells me, hey, no, you're not going to give my husband any pills. Say, well, they're safe. I mean, and you can definitely go from there. You mentioned products in your packet. Tell me about them. On that first visit, that you don't know anything about that patient, they're reading. What are they reading?
The packet, so I'm oftentimes running behind in clinic. I don't like it, but I like to talk. My patients like to talk. So inevitably, I tend to run behind. So the packet gives them something to do so they're not just staring at the wall. But in the packet, it also has recommended products. I've had patients, and that's important for both medications, understanding medication assistance programs so patients can get medications for very cheap, and vacuum erection devices or vibrator products, tension bands, everything and anything. When patients used to ask me, well, what vacuum pump do you recommend? My response was, well, I don't know, get whatever you want.
That's my response right now.
Yeah. But if you ever look online to see what products are out there, there are a ton of products. And so if our patients get one that's not a good product or they don't have good customer service, they're going to come back in and they're going to say it doesn't work. But good quality vacuum pumps work. Now, do I think that vacuum pumps are great before sexual activity? No. And I tell patients that. They're cumbersome. They change sensation. They can cause bruising and swelling. So I don't think they're great before sexual activity, but they are incredible for penile rehabilitation. So I know, penile rehabilitation, I'm very aggressive with it. I recommend that anyone who's not getting daily erections gets a vacuum erection device, which means I have to set them up for success and actually provide recommended products. So how do I come up with that list, or how did I initially do that 2 or 3 years ago? Well, I was working with a pharmacist in the community. So we have a lot of providers at our institution, but we don't have all the providers that I need on my team. And that's where I reached out to people in the community that could help take care of the mutual patients. And so I met this guy, Robbie, at a local compounding pharmacy who actually has interest in building a men's health portfolio. He was already filling Trimix for patients. And so he actually did the work. He reached out to vacuum erection device companies to find out where's the good customer service, folks. What are the good products? He got demo products and he continues to do that. So we offer in a list different vacuum pumps at different price ranges. So initially I was saying, hey, if you want the best product, here it is. It's on the expensive side. It's about $300 to $400. Well, a lot of people are going to get the product if I recommend it, but it's going to be cost prohibitive to some folks. So then Robbie, my pharmacy colleague, found one at a lower price point. So now I can give this to patients to say, the first thing you do is you decide how much you're willing to spend, and then pick one of these products on this sheet. And some of those products are ones that one of my patients, got a product and said, Dr. Pearlman, I got this product. It's $125. It works great. Tell your friends. And so then I tell my friends, and I'll tell patients, look, I have an N of 1. One person said he liked this product, but I trust that guy. He's a good guy. And so that's why I put it on this sheet. And you know what? That's all patients need to hear. They want to know what recommended products are. We in healthcare we're not taught to provide recommended products, but it could be, I hypothesize, one of the most important things we ever do for our patients is to give them a place to start. And then they get the product. And then when they come back in 3 months and we say, did you get the vacuum pump? Did it work? Then we don't have to hear, no, I didn't know which one to get. They got it. I can say, why don't you stop by New Cara on your way home and say, Amy sent you, and ask for Robbie, and Robbie's going to hook you up. And you know what, Jose? Robbie hooks him up.
and Amy, so is that list available for nationwide, or is just something local?
So they're all available online. So we have the website link. So I can definitely provide that for you. And there are a lot of good products out there. These are just 5 at different price points. And so I'm happy to provide that list. And it just gives people a place to start.
Do you have any at your website or the list?
I don't have it on my website. I have it actually as part of an educational document that I created with one of our pelvic floor physical therapy colleagues who has a particular interest in penile rehabilitation. So now we have 4 pelvic physical therapists, and they're all on board with pelvic floor rehab and genital rehab and penile rehab. So I don't see every single person who has erectile dysfunction or who would benefit from penile rehabilitation. So everyone who interacts with that patient should be able to give this sheet of paper, and they have the copy as well, so that we're all giving a shared, consistent message, We've agreed. What is our rehab protocol? It doesn't have to be perfect. Again, it's just a place to start. And we tell patients the goal, 10 minutes a day. If you want to do more than that, that's fine. But let's start somewhere.
So, Amy, in terms of patient education, what do you tell about? Sometimes I get patients that at the end of the day, they say, well, it's my wife or my partner. How do you talk up to them about that? Because I say, well, I'm not a sexual specialist. I mean, I can do the surgery, but in terms of giving you 30 minutes, 45 minutes, well, somebody else. But what can you offer the patient? What do you tell about the patient about intimacy, about the partner relationship?
I think that's one of the hardest parts about our jobs, Jose, as urologists and men's health specialists, is like, we sometimes have to put on that mental health provider hat. Like, we can't do our jobs without acknowledging the impact of a relationship and performance. And so that's why I run behind. That's why I rely on our advanced practice provider team to keep us running in clinic, so that sometimes I just sit in the chair and I say, I'm going to be here for the next 30 or 45 minutes because we got to talk. But I can still have patients being seen while I'm having those conversations, which are so crucial to have and also really hard to do. But I talk about anatomy. I start with the basics because most men, most people are never taught the basics of their body. And that's where I begin. And I don't make any assumptions that anyone has ever done that before. And I'll ask patients, where are you? Like, how much of this do you understand? And most people just want me to start from the beginning. So then I'll step out of the room for a second and I'll bring in some models. Sometimes I come in with a whole bunch of stuff and I lay it on the table and I say, let's talk about your pelvis. And I show them a cross-sectional view and I say, let's talk about your bladder. And I go through the plumbing. And then I talk about the pelvic floor. And then I talk about the erectile tissue. Because again, it's really hard to offend someone if you break down erections into basic anatomy. You have 2 sponges in your penis. That sponge needs to fill with blood to get a good erection, and it needs to stay in there to maintain the erection. I use a lot of key analogies as well, but I also bring a sponge into the clinic room. I had an actual patient bring in a sponge that you could tell has not been under the faucets for a very long time. And he took that sponge and he put it on the table and said, Amy, this is my penis. And I'm like, yes, that's why we need to rehab your penis. That is your penis, because the penis is a sponge. So I'll bring in a healthy sponge and a sponge that hasn't seen water in a very long time. And I say, this is why rehab is important. But I also, even when, the couple is in the room. So one, I acknowledge when the couple is in the room, I say, this says so much about your relationship that you both are here today. That is a very special bond that you have. Thank you so much for coming today. So I acknowledge that at the start of the visit. And I say, we're going to forget about penis and vagina for a second. We're going to forget about masturbation for a second. And we're going to talk about the health of your genital tissue. And you can't offend anyone when you just talk about the health of tissue. And I use an analogy by saying, it's just like your shoulder. If, the shoulder, it was meant to move, you've got to rehab it. And if you are lifting weights and you're working your biceps for 6 months, and then you say, I'm not going to lift my biceps for 6 months, you're not surprised when your bicep muscle shrinks. But yet men are so surprised when their penis shrinks because simply nobody has told them that that could occur. But when I talk about that sponge analogy and saying the goal is to put the sponge under the faucet every day, just for a little bit, that's a healthy sponge. But if you don't do that for a year, it's old and crusty and will not expand like it did a year before. And people understand it. And that's how I get a lot of guys to do penile rehab. Now, some guys will say, is it too late? I haven't had an erection in 10 years. And I say, it's never too late. Now, are we going to get you back to what you were when you were 19? No. But if we can make progress, if a guy can see in real time that he's using a vacuum pump and he gets some return of length and or girth, that gives the person hope. It makes him optimistic. And he gets back on the saddle and says, let's do this. So people just need to see progress. Nobody likes going to the gym and lifting weights and not seeing any progress. And that's where penile rehab and the vacuum device can help empower patients to make better decisions and to kind of move forward in that ED process.
And you try to tell them 10 minutes every day? Is that what you tell them? Okay. And Amy, in terms of the partners, I mean, You also have videos talking about sex toys and tools for how do you avoid that conversation? And do you have a list for that also?
So what I've realized more recently, maybe in the last 6 months or so, is I'm always thinking about what is my role as a woman in men's health. And that changes all the time. Sometimes it's an advantage to be a woman in men's health, and sometimes it's not, it's a disadvantage. And sometimes, most of the time, it doesn't really matter. But what I'm realizing is one of the most important roles that I can do as a woman in men's health is to educate men about the female body. Now, a lot of men that I see, they don't necessarily have sex with women, or they're just, interested in sort of improving for solo, sexual activity, which is all fine. But my role for men, especially when they come in with female partners, is to say, look, your penis is super important. I've gone into over $200,000 worth of debt to fix the structure and function of that organ. But also, most women don't orgasm with penovaginal intercourse. So let's talk about the clitoris. And then I have another model of a vulva and a vagina and a clitoris. And I bring it in and I say, this is where the clitoris is located. So while your penis can help your partner experience pleasure, you don't have to be everything for everybody and perform 100% of the time. And I say that so you can take a breath of relief and understand there's still ways that you can have a satisfying sexual encounter with your partner without your penis working all the time. And I always look at the expression of the woman or the partner in the reel, because sometimes the guy is like, oh, yeah, I know that. And then I look at the partner and she's like, oh, yeah, that's really interesting. Oh, yeah. But I also bring up sex toys and tools in that conversation. And I tell them, like, look, there are sex toys and tools for people who are penis owners and vagina owners, and you can use them alone and together. There are couples ones. And I also tell people that as people get older, you just need more stimulation to the nerves. The nerves don't work as well. But I use this analogy of when you're in the kitchen and you're making dinner, like if you wanted to make spiraled zucchini spaghetti, Jose, would you consider doing that like one by one?
No, I need to buy the...
Like that would be absurd. That would be ridiculous. And yet we have these expectations for ourselves and for our partners that between our mouths, our hands, and our genital parts, we have to satisfy our partners over our entire span of the relationship. And that is just not going to happen all the time. And that's where tools can be helpful. It makes it easier. It spices it up. And also it can provide people with incredible orgasms. So even though we can, like the treating the erectile dysfunction, that is some of the easiest stuff that I do in clinic. But allowing a couple or helping a couple to reach really satisfying, sexual activity, that is different. That is much more than just fixing a penis and getting it to be rigid. The other thing too is people have other stuff going on in their daily lives. So if they get home from work and they might think, God, it's a lot of work and I have arthritis and I just don't have the energy to take 30 minutes to masturbate to get off. It's like, then get a masturbator that vibrates. Of course that would feel good.
No, exactly. And like you said, I mean, most of the time they're coming because of the partner, and they come with the excuse. My girlfriend left me, my wife left me. But like you said, I mean, unfortunately, I just push pills. I say I can do it pills. I can do the trimix. We can do the pump. But really, that education that you're just telling and talking about what other stuff they can do so that they don't feel powerless.
And I also talk about how erections are separate from orgasm, which is separate from ejaculation. Someone could have a fully flaccid penis and still have an incredible orgasm. And that could be helpful, especially as, let's say, someone is going through ADT or radiation for whatever, prostate cancer or another cancer or chemotherapy. So maybe they're not having penetrative intercourse with their partner, but that's an opportunity for them to still engage in rehabilitation and to still use these different toys to experience pleasure. Because the hard part, when couples come in 10, 20 years after they've stopped engaging in sexual activity, like let's say you put an implant in that guy, that implant, just because it works doesn't mean their partner, who now is kind of over it, they're like, I don't care anymore, I'm over it. Like the only way to prevent that conversation from ever happening and for someone to lose interest because it was just so much work before is to prevent that from ever stopping. let's not stop the intimacy. We just have to be more creative as people are going through certain life events to keep that intimacy, even if it's not in, what we would think of as, vaginal intercourse.
That's awesome. Yeah, definitely. And nobody's talking about that. And that's the truth. My patients, they don't have the guidance. We need somebody like you in Orlando to talk to the patients, because really that's what they want to hear.
Yeah. And it's hard to offend people. I have the Iowa farmers. I have religious people in my clinic. And these people, some of them are like, oh, yeah, we already use vibrators. And I'm like, that is awesome. That is incredible. Check out some additional products if you were interested. And some people are a little bit not as comfortable with that. But I say, look, I'm not asking, like, you can go online and you can get a product, but we also have to think about the implications of someone going online because, okay, so maybe like 5 years ago, I'd be looking on my Facebook and like, oh my God, does everyone else get black yoga pant ads too? How do they know? So if we ask our patient to look up a vacuum pump or a penile constriction band, there are implications of what is going to show up on their Amazon account and their Facebook account. And maybe they don't want their grandson, when the grandson is on their computer later that week, to see what pops up. So it's really helpful to have places that we can send our patients where they can go in person to pick up these products and talk through them with people. And Jose, we don't actually have to do that. Again, we don't have to be everything for everybody. We just have to find the people who want to have those conversations. So for me, it's my same guy, Robbie, at the compounding pharmacy. He has an entire cabinet of vibrators. And so I say, go to New Cara, ask for Robbie. Robbie brings them back into a separate consultation room and goes through all those products.
So Robbie needs to start doing virtuals.
Yeah.
And sending patients to
Yeah. But it's just helpful for everybody in their community to reach out because everyone wins in the end. It brings people into his pharmacy who may have been going in for a different reason, and then they pick up products. And it also means that, like, when they leave my office, they're not going to perseverate over it or think about, should I even go to this site? They are en route to Robbie's office by the time I'm seeing the next patient and will actually get those products. But it normalizes the conversation too, because there are some people who will never show up in your office or my office because they don't want to see a healthcare provider to talk about these things. Those are the people who go to these online pharmacies or who go to, sex stores and websites to get these products because they don't want to hear it from us. But the people who show up in your clinic and the people who show up in my clinic have already entered into the medical system. So a lot of those people will want us and prefer us to medicalize their thing. And so sending them to a pharmacy medicalizes it and says, look, this is just a sex tool. The words we use matter. So using sex tool instead of sex toy can also be helpful.
Nah, like you said, I mean, I tell them, hey, go online. But definitely online, there's a bunch of products. They buy one that doesn't work. They get frustrated. They either come, they don't want to do it again. They wasted $200. So that's why I need your list.
Yeah. and the customer service for those companies is critical because then I can say, look, these companies, if they're a little bit more expensive, they're great quality. They have incredible customer service. Because if a patient has a question about it, I'm going to say, I don't know about that specific product. Reach out to their customer service, but that's not good advice if there's no good customer service that's going to pick up the phone. So ultimately, it's a reflection on you and it's a reflection on us if we recommend a product that's not good. And so when I work with this pharmacist, he understands that for himself too, that it's a reflection on him and therefore he stocks good products.
Yeah, like we have talked about the network that you have created. We have talked about the importance of also having that digital footprint, educating the patient and offering the patient multiple things, not just mention it, doing the real deal. Hey, go here. Because most of the time they need direction. They hear from maybe some PCPs talk about it, but really they come to us to have a solution. And sometimes, at least I sometimes fail because of time, because of multiple reasons. I mean, it is what it is. I see 45 patients in the office. So, I when I started at urology, I wanted to do a men's health clinic. That's what I wanted. But I like doing stones, I like doing BPH, and it is what it is. But Amy, anything else that you want to add to the listeners?
A lot of what we discussed today, they're different hats that I get to wear on a daily basis. And when people ask like why urology or why men's health, it's because sometimes all in a single day, I can be an educator and a researcher and a mentor and a teacher and a listener and a surgeon and an advocate and a podcaster today, and a businesswoman and an innovator. And I can work with device companies who come up with these products to understand the engineering, behind these different products. And that's what makes our job so much fun. It's why so many of us end up choosing a field in urology. So the big piece is for each person to understand for themselves, what types of conversations do you want to have? What do you want to talk about? When I was deciding on a specialty within urology, I loved doing robotic surgery. But for me, I didn't really like talking about prostate cancer. And therefore, I don't do robotic prostatectomies because I didn't enjoy that discussion or that conversation as much. I love talking about sex. I get to talk about sex and satisfying orgasms all day, every day. I don't know why more people don't want my job, but there are some people that don't want to have those conversations, and that's fine. So understanding for ourselves, when it comes to this digital footprint, how do each of us communicate best? I love communicating on video. I am very passionate. So when I'm on audio only, I come off a little aggressive. Okay. I understand that about myself. So I like communicating through video. Now, some people may prefer communicating through written word. Fine. Then that's how they can do, their communication with patients. But I don't think the answer is for all of us to get Instagram and YouTube and Twitter and TikTok and to communicate all of those platforms. If one, we don't enjoy it. And if two, we're not good at it and don't come off well on those platforms. So we have to be honest with ourselves to understand what are we good at and what are our goals. And then when it comes to developing these relationships with these comprehensive teams, when I think about this comprehensive men's health clinic, it is not a person seeing all the different providers they need to see in a single day. That's not the model we have, but it's seeing the right provider at the right time for a specific reason. And it might be on different days, and patients are okay with that as long as they're seeing the right provider. And it's understanding who are the people within my academic institution who can help my mutual patient. And if a person I need is not in that academic institution, who can I network with in the community, in the state, in the country, worldwide that can help my patients? There is someone for all of our patients. And our role as healthcare providers is to find those people rather than putting the onus on our patients to find those people. And that it has to do with referrals, and it also has to do with products. There's nothing wrong with us recommending specific good products for our patients that will help them. I don't get any money off the products, but there are plenty of urologists in private practices who can make money off the products. And you know what? There's nothing wrong with that either.
So, Amy, thank you for being a part of BackTable. And we'll talk about sex soon.
Sounds good. Good to be here. Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team lead is Kieran Gannon, with support from Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Ishad Sangwan
and Vedavi Patwardhan.
Social media and PR by Chi Ding.
Thanks again for listening, and see you next week.